This week on the ASC Podcast with John Goehle, we discuss pharmacy and drug compliance, tips and tricks to make your operation more efficient, and the latest news and upcoming events.
Welcome to the ASC Podcast with John Goehle, a weekly podcast for anyone interested in the freestanding ambulatory surgery industry. This week's episode is sponsored by Ambulatory Healthcare Strategies, one of the nation's leading full-service ASC regulatory compliance consulting firms, and the Regulatory Compliance series of books for ASCs by John Goehle and published by Eden Group Development.
Welcome to episode 14 of the ASC Podcast with John Goehle for April 2nd, 2018. Recording from our studio here in Rochester, New York. This is Jenna Alvarez, Senior Nurse Consultant with Ambulatory Healthcare Strategies. I'm here with Sue Cronkite, also a Senior Nurse Consultant with AHS, and our owner-operator of Ambulatory Healthcare Strategies, John Goehle, who is one of the nation's leading ASC industry experts in regulatory compliance, finance, and administration. Welcome, everyone.
Welcome.
Thank you.
So this has been a very busy week for all of us. John, what was the highlight of your week?
Well, I had an opportunity to get out and see a lot of our clients this last week, some very dear friends. I met with Beth Hogan, a friend of mine out in Glens Falls with the Northern GI Center. She was telling me that she had just come back from the AORN conference. Dorothy Zimdahl, I know, was there with her, and just talked about what an excellent conference it was this year. And she mentioned that she learned a lot about nurse retention issues. So she promised to send me some information that we might be able to use in an upcoming podcast. And I think in general, we've just getting a lot of good feedback this week from people that I met about the podcast. You know, I think they like the changes that we've been making and some of the work that we're doing on the website now. Certainly the name change has been a fantastic boon. Our listenership has actually increased quite dramatically. I'm not sure if that's because of the change or maybe all of the excitement that surrounded it, but definitely I think we're on a roll here, and it's great to have you guys working with me on this wonderful thing.
It's a lot of good news. John, can you talk about some upcoming events?
Sure. This is a regular part of our podcast now, just to kind of give you an update on everything that's going on. If you wish to have your event included in the podcast, please send event information to info@ascpodcast.com. My friend Beth out at the California Association for Surgery Centers wrote me and reminded me that the California Ambulatory Surgery Association annual conference will be September 5th through the 7th in 2018 in Huntington Beach. And they also have a CASA infection prevention seminar November 7th to 8th in 2018 in Costa Mesa. You can get more information about both of those events at their website, which is www.casurgery.org. In addition to that, ASCA 2018, of course, is coming up. Their website is www.ascassociation.org. The event is April 11th through the 14th in Boston, Massachusetts at the Heinz Convention Center. We're all going to be there. Please join us. I think I'm doing 3 speeches there. The New York State Association of Ambulatory Surgery Centers, and their website is www.nysaasc.org. Their upcoming meeting is May 17th and 18th in Albany, New York. And again, go to their website for more information. The New Jersey Association of Ambulatory Surgery Centers has their 8th annual Ambulatory Surgery Conference, June 12th through the 13th at the Wilshire Grand Hotel, and you can get more information at www.njaasc. We also wanted to remind everybody that we have 2 tests coming up for the various credentials, the new CAPE, CAIP, infection prevention credential. The first exam will be in October. It's an online exam at a testing center. You have to sign up through the www.aboutcape, that's ABOUTCAIP.org website between August 1st and August 31st. And the next CASC test is going to be at the ASCA 2018 conference. Unfortunately, it is too late to sign up for that, but the next test after that will be an electronic test or an online test at a testing center. That's going to be July 1st through the 31st, and you have to sign up between May 1st and 31st, again, at the CASC website, which is www.aboutcasc.org. We're going to create a calendar on our website so that we can update everybody on all these events, and hopefully that'll become a good tool for everybody in the industry so they know what events are coming up. Sue, you had some things to talk about this week on the news.
I want to talk a little bit about the opioid shortage as well as the epidemic of overdoses. Well, as we know, the shortage of opioids for healthcare facilities continues with really no end in sight at this point. The tragedy of opioid addiction and overdose is still growing. I think that we that work in healthcare can be a part of the solution. I saw an article in Targeted Oncology from March 25th that referenced a study in which gynecologic surgeons at Roswell Park implemented an ultra-restrictive opioid prescription protocol for minimally invasive and ambulatory surgeries. Some patients were given opioids, but only a 3-day supply, and other patients were given prescription-strength ibuprofen and or acetaminophen. This protocol reduced the number of opioid tablets given at discharge by 89%, from an average of 31.7 down to an average of 3.5. And surprisingly, although at the beginning the majority of the surgeons that were surveyed before the study expected the patients to be unhappy and have much more pain, they found that actually there was no increase in pain scores and no significant increase in patients requesting refills. So it actually worked out quite well. According to the FDA, more than 40 people a day die from overdoses involving opioid medications. The FDA Commissioner, Scott Gottlieb, said, and I'm going to quote this here, we can and must do more to arm physicians, who are the gatekeepers of prescription opioids, with the most current and comprehensive guidance on the appropriate management of pain. Many people who become addicted will first be exposed to opioids through a lawfully prescribed medication. Often it's for an immediate release formulation of an opioid drug. We need to do more to ensure that prescriptions are written for only appropriate purposes and durations of use. Opioids should rarely be our first resort when treating patients in pain. The FDA is developing a revised blueprint for opioid prescriber education that will be finalized later this year. Along that line, I want to mention Jesse's Law. This is a new law which involves putting the addiction history of the patient in a prominent place on the medical record, similar to what we do with allergy information at this time. Now, this would only be done with the patient's permission. This law is based on a Michigan woman, Jessica Grubb, who was a recovering addict who had surgery for a running injury. Her addiction history was mentioned several times in the medical record, and her parents had actually asked the doctors to be cautious and give opioids only with strict supervision. She was discharged with a prescription for 50 oxycodone tablets and died that night from an overdose. The doctor who discharged her said he was not aware of her history and that Jessica had not informed him. Of course, the patient does have a big responsibility here, but I think, having that information would really allow the provider to just be more cautious and maybe talk to the patient about other options and utilize, some different techniques. John, you wanted to talk about an issue in New York.
Sure. So there was an article in the March 16th issue of Becker's ASC about the Mohawk Valley Health System, the Faxon campus in particular in Utica, New York, deciding to terminate their procedures at their outpatient surgery center as a result of the growing number of ASCs in the area. The reason I bring this up is I've actually had quite a number of emails from clients of ours and other people in the state asking, what was up with this and what I thought of it. I think in general, we're starting to find that we are finding more and more competition among ambulatory surgery centers, and I think the hospitals are feeling the pinch from this. New York has often been isolated from that because we had so few ambulatory surgery centers up until very recently, but now I think it's starting to happen here. So just something to keep in mind as we're watching, the development of new ambulatory surgery centers, that it's no longer a given that you're going to be totally successful, that your volume is going, that if you build it, the doctors are going to come. Now that there's competition, you not only have to make sure that you're doing a good job for the community, but make sure that you're doing a good job in competing with the other centers in providing high quality services to the physicians as well as the patients.
Thanks, John. We're going to take a short break and we'll come back and talk about pharmacy. John, you've been working on the ASCPodcast.com website. Can you tell us what new tools are available there now?
Certainly. So we've decided that we really want to make that website a very useful tool for not only our listeners, but anybody else in the industry that might want to visit and get information, up-to-date information in various areas or aspects of ambulatory surgery centers. So I've added some new tabs at the top of the website, including starts off with John's blog, which are all the blogs that we posted so far related to the weekly topics. We also have a new tab for the podcasts, which so every podcast now actually has its own page, and moving forward we're going to be adding material to supplement the podcast, including links and references that we've discussed, as well as publications that you may wish to obtain in that particular area. And then there's also a new tab for resources, which is a growing page that provides valuable resources for various ASC topics. This is still under development, but I hope to be a reference that you can go to find books, tools, and links to the actual podcast where these topics have been discussed.
Thanks, John. Our goal here at ASC Podcast with John Goehle is to provide timely information and resources for our listeners. This week, we are focusing on pharmacy and drugs. This is always a major area in an ASC. Surveyors certainly focus on it during surveys. The importance really can't be overstated. National debates continue about opioid use and maintaining security of the drugs. Our discussion will focus on what is required by CMS and what surveyors look for. We'll also have a discussion of USP 797, an often overlooked document that is an important part of the regulatory environment. John, let's start with you in the CMS regulatory framework.
Sure. So pharmaceutical services is in section 416.48 of the condition for coverage for ambulatory surgery centers. And this states in part, the ASC must provide drugs and biologicals in a safe and effective manner in accordance with accepted professional practice and under the direction of an individual designated responsible for pharmaceutical services. The standards include administration of drugs, which states drugs must be prepared and administered according to established policies and acceptable standards of practice. Adverse reactions must be reported to the physician responsible for the patient and must be documented in the record. Blood and blood products must be administered by only physicians or registered nurses, and orders given orally for drugs and biologicals must be followed by a written order signed by the prescribing physician. Now, one point I'll make here in this area is that it does note that it has to be under the direction of an individual designated responsible for pharmaceutical services. That is sometimes interpreted by people that it would be a pharmacist. But as we all know, in ambulatory surgery centers, we don't have full-time pharmacists. So the person that would be responsible is a physician, most likely the physician whose drug license is being used to purchase the drugs used in the ambulatory surgery center. Moving on to the interpretive guidelines related to the administration of drugs, there's a note about acceptable standards of practice means that drugs and biologicals are handled and provided in the ASC in accordance with applicable state and federal laws, as well as standards established by organizations with nationally recognized expertise in clinical use of drugs and biologicals. So the types of organizations that we're most likely going to be looking to for that would be the Institute for Safe Medication Practices, the ISMP, and USP, which is the U.S. Pharmacopoeia.
Thank you, John. Jenna, can you talk about ISMP and the look-alike, sound-alike, and the high-alert drugs?
Sure. So first I wanted to go over, in addition to the CMS conditions for coverage, there also are standards for the accrediting organizations regarding look-alike, sound-alike, and high-alert drugs. So I'm just going to really quickly go over those, and then we'll get on to what the requirements mean. So AAAHC requirement 11F requires centers to have procedures in place to prevent errors from look-alike, sound-alike, and high-alert medications. This must be evidenced by maintaining a current list of look-alike, sound-alike medications, as well as high-alert medications, and then having processes in place to prevent errors from administration of these medications. Similarly, Joint Commission has two requirements regarding these as well. MM010103 requires the organization to safely manage high alert and hazardous medications in accordance with nationally recognized guidelines. And MM010201 requires the organization to address the safe use of look-alike, sound-alike medications. And similar to AAHC, the elements of performance require the facilities to develop lists of high alert and look-alike, sound-alike, or LASA medications specific to their organization, and then take action to prevent these errors. So one of the best resources out there for identifying LASA and high alert medications is the Institute for Safe Medication Practices that John and Sue had mentioned. This is commonly referred to as ISMP, and their website is ismp.org. So ISMP publishes a list of look-alike, sound-alike medications, and these include things such as epinephrine and ephedrine, or dopamine and dobutamine, and it has the tall man lettering for you to use that are the standardized ways to identify the two different medications to avoid confusion. They also publish a high alert drug list specifically for community and ambulatory settings. Those include categories of drugs as well as specific drugs. So as far as categories go, all insulins, all opioids, all pediatric liquid medications that require measurement. Examples of specific medications on the high alert drug list for ambulatory settings are heparin and midazolam, liquid for sedation of children. So in addition to just identifying these medications, you can't just take the list from ISMP. You have to find the drugs on your formulary that are in your facility that are on those lists and identify them specifically. And then you also need to actually identify processes in place to prevent errors from occurring with those medications. So this may include getting labels to put on the medications for high alert, or using the tall man lettering for the look-alike, sound-alike. You should also have a policy for staff to take extra precautions when using these drugs. There isn't anything specific as to what you need to do, but sometimes this involves having like a 2RN sign-off for the high alert medications, just as an example. And then also show that you provide training on the handling of these medications and prevention of medication errors.
And let me just mention that this is actually a frequent area that I find when I'm doing a survey, a problem in surgery centers, that often they're not doing a very good job of identifying the drugs, or they'll just post a list of all the ISMPs. I recently was in a place where they were actually using a 2008 version of the ISMP list, which, by the way, is very different than the 2018 version of it, which I found out when I looked at that list. So make sure it's up to date, and as Jenna mentioned, make sure that just don't post that list inside the cabinet. Make sure that you identify those drugs that you're using specifically. So I'm going to go on to USB 797. This is a document provided by the U.S. Pharmacopoeia. The document's been around quite a number of years, and it provides guidance for compounded sterile preparations. In 2016, APIC, the Association of Professionals in Infection Control, issued the APIC position paper, Safe Injection, Infusion, and Medication Vial Practices in Healthcare, which provided guidance and references back to the USP 797 standards. So both of those documents we'll post on our website for you to review, but both of them basically have become the guiding principles for the issues that we're going to talk about in a few minutes with compounding of sterile preparations. So USP defines compounding as the preparation, mixing, assembling, altering, packaging, and labeling of a drug delivery device, or device in accordance with a licensed practitioner's prescription, medication order, or initiative based on the practitioner, patient, pharmacist, compounder relationship in the course of professional practice. Sterile compounding involves medicines administered through injection and IV, or directly administered into the eye. Non-sterile compounding involves medicines administered orally by mouth or topically, for example, on the surface of the skin. So USP 797 requires compounding processes involve no more than 3 commercially manufactured packages of sterile, non-hazardous products. This is very important because I found frequently, and sometimes this is in pain management in particular, nurses mixing more than 3 commercially manufactured packages. And this also happens with eye mixtures, as you might recall, with eye drops, where they're trying to mix a number of these drugs together. So be very careful with all those. Those do fall under USP 797. So during the preparation, aseptic technique has to be followed, and if it's not immediately administered, the compounding medication must be under continuous supervision to minimize the potential for contamination. Administration of the compounding medication begins no later than 1 hour following the start of the preparation. And unless it's immediately administered by the person who prepared it, the compounded sterile preparation must be labeled with the names and the amounts of all ingredients, the name or initials of the person who prepared it, and the exact 1 hour expiration date and time. And Jen, I think you mentioned if there's any more room left on that label, they also have to put the patient's name and date of birth, right? Mm-hmm. So clearly this is something, if you're going to do this sort of thing with compounding, you probably want to administer it right away, because the amount of time it takes to write it all down would probably negate the whole process of getting this done ahead of time.
So, John, what you're referring to is compounding that's being done in the surgery center.
Correct.
And if you're using more than 3, you need to really send it out to a compounding pharmacy.
Or if you want to be able to use that drug more than an hour after it's been drawn up, you're going to want to use a compounding pharmacy for that. Let me also just mention a couple little issues that tend to pop up during surveys. Obviously, make sure that you read the labels carefully on all the drugs so that you know what is single dose and multi-dose vials. As much as possible, don't use multi-dose vials for more than one patient. So a lot of our organizations now that purchase multi-dose vials have a policy that they only use it on one patient. If you do use a multi-dose vial on more than one patient, the drugs drawn into the syringe must be drawn outside of the patient care area. So that tends to be kind of inconvenient. So you need to remember that you cannot be drawing it up in front of the patient or near the patient. It has to be outside of the patient care area. Another area that is almost a regular when I do a survey is any drugs drawn up and not used immediately must be labeled with the name, dose, and the initials of the individual drawing it up and the time drawn up. Often they do label it with the name of the drug and the dose, but they don't do anything about the initials and the time drawn up, and that is an issue that's cited.
And I know that was something that AAHC actually got more specific about this year in their new guidelines.
Absolutely, and yet I'm still finding that people are not following it. And I know it's difficult. The anesthesiologists are always screaming about this because they have so little time to do things. To do that extra step of putting the initials and the time is time consuming, but unfortunately it is the rule and they have to follow it.
Okay, we're going to take a short break, and we'll be back to talk about tools and tricks for running your ASC. Welcome back. Now, this week we thought we would provide a number of tools and tricks that can make your lives easier. These are just a number of ideas we thought you might be interested in. John, can you tell us about some of them?
Yeah, so first of all, this is started because I looked at the tools that we use in order to create this podcast. And for example, we use Google Docs, which is it's a free service that you can get from Google with your Gmail account. And we actually use Google Docs while we're doing the podcast. Our script is there, not that things are scripted necessarily. There's a lot of ad-libbing here, but we actually create that throughout the week as we're getting prepared, because none of us are in the same place for most of the week. And we can see each other working simultaneously. And what's kind of neat about this Google Doc is that we can actually, while we're doing the podcast, make changes to the script and see each other doing that as we're going along. It dawned on me that's the type of tool that's really convenient for things like minutes or for preparing an agenda for a meeting. Or if you're doing a board meeting, for example, over the telephone, you can be looking at a Google Doc that has all that information in there and actually see in real time people making changes to it or adding their comments about it. I think it's a great tool. It's been a great tool for us here. And Google Docs also has the ability to do spreadsheets online, which could be useful for you if you're creating quality improvement studies and need data gathering. The one thing I'll warn you, though, about Google Docs is it is not HIPAA compliant, so don't put any patient information in there. And that should be said for all the tools we're going to talk about today, or the 2 tools we're going to talk about. Second tool that we use extensively within our company is a product called Evernote, which is a great tool for note-taking. It is free for low-volume note-taking, and it could be used, again, for organizing board and QAPI meeting minutes. Use it to take notes during the meeting. We actually use this tool for our site visits. When we go out and visit our centers, we create notes, which all of the other team members in the organization can read almost in real time. It's not quite as real time as Google Docs are. But as we're going through the meeting, we document what's going on during the meeting, and in the background, sometimes our staff members are already writing up the minutes for that meeting, which makes us very efficient and actually impresses the heck out of many of our clients when they see that we can issue minutes very quickly after the meeting.
And you can also take pictures right into the program if there's issues, equipment that needs to be fixed, or we see something on the wall that needs to be fixed. We can take a picture of it and say, hey, this is something for infection prevention as part of our environmental rounds that we noted needs to be fixed.
Right, and we actually use that this week. We have a new center starting up, and we were, unfortunately, one of the people on the development team was not available, and we took pictures. She has access to Evernote and was able to see those pictures going in there and react to that pretty quickly. Well, good thing about Evernote is it does sync to the cloud. As we mentioned, you can share data automatically. Again, don't use it for PHI. But you can use it on multiple devices. So as Jenna was saying, sometimes we take the pictures on our iPhones and it links up to our desktop version of it. The last tool that I like to talk about is our training programs. We believe that developing an annual training binder with all of our training programs, all of our annual mandatory training programs, is a great tool. We find this especially impresses surveyors when they come in. So our training programs, our annual mandatory and orientation programs, are split into 3 areas. The first one is general education, which includes things like annual HIPAA training, bloodborne pathogen training, etc. The second part is training on the programs, such as your QAPI program, your safety program, your corporate compliance program, your emergency plans. And the last section is training on specific policies that must be reviewed on a regular basis, such as your Code Blue policy, your transfer policy, abbreviations, etc. So we create a binder every year for all of our clients that include these 3 sections. The first section has a lot of PowerPoints on general education. The second section has a copy of the QAPI plan or all the different plans that the organization has, as well as our notes on that. And our third section includes a copy of those specific policies and our notes on those policies that have to be reviewed annually. And then what we do is we create a test that goes through all of the things that are included in this annual training program and the orientation program. And the test helps us to demonstrate that the employee has actually been paying attention during the training program, as well as, or if they did it individually without an actual trainer, that they read through all that information in the binder. And what we do is we take this test and a 1-page summary of all the training that was reviewed in that binder or during the annual program, and with checkoffs, and a signature of the trainer and a signature of the individual who was being trained. And we include that summary with the sign-off in the employee folder just to demonstrate that they've gone through the orientation program and the annual mandatory education program. Surveyors love looking at that 1-page summary. They just go through that checklist and they can see right away that all the training has been done. We actually had a situation a couple weeks ago where a surveyor was reviewing the program, looked at the binder, loved the binder, and actually decided to take a couple test questions. And it was kind of amusing because, first of all, they looked at me and they said, "We don't know the answer to this question. Do you?" And I looked at it and I said, "No, I don't. And the only way that I would know is by actually going in and reading this specific organization's plan." So that demonstrated to them that we're not just brushing over these things, that our program is specific to the needs of the organization and that we were testing them truly to make sure that they were reading through it. So that's another trick. I think we'll kind of add this periodically, these tips and tricks for people to use. And if you have any tips or tricks, why don't you send them to us at comments@ascpodcast.com, and we'll try to read them on the air also.
Sounds good. Well, that's it for this week's podcast. Please join us again next week for another episode of the ASC Podcast with John Goehle. And don't forget to tell your friends and colleagues about the podcast and hit that subscribe button so you don't miss a single episode. John, I understand you have a special offer for our listeners this week.
Yes, indeed we do. So as a special offer for all of our listeners on this podcast, we're offering a significant discount on my book, The Survey Guide for ASCs, a guide to the CMS conditions for coverage and interpretive guidelines for ambulatory surgery centers. This book, as hopefully everyone knows by now, is the leading book in the industry for preparing for a CMS survey. Has a lot of information about what the regulations are, the interpretive guidelines, and really has a nice index to be able to find this information quickly. I find it's particularly helpful for those difficult questions we sometimes get from the physicians when they say, okay, show me the regulation. And they can pull this book out and go right to that section very quickly. So in order to take advantage of this deal, go to the ASCpodcast.com website, which is ASCpodcast.com. And follow the link for this week's episode. You will see a link to purchase the book.
And how long is this offer available?
You can purchase this book at this discount through April 30th.
Thanks, John. So please head over to our website, ASCpodcast.com, to take advantage of this great offer. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all the rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute, legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development, all rights reserved. We would like to thank this week's sponsors, Ambulatory Healthcare Strategies, one of the nation's leading regulatory compliance and financial oversight firms. For a free consultation, contact John Goehle today at 585-594-1167 or through email at info@ah-strategies.com. Our other sponsor today is Eden Group Development, which publishes ASC Regulatory Compliance Series, the ASC industry's leading books, including The Survey Guide for ASCs, a guide to the CMS conditions for coverage and interpretive guidelines for ambulatory surgery centers, and Ambulatory Surgery Center Governance, a guide for ambulatory surgery center owners and governing body members. These must-have books are available on Amazon and Barnes & Noble or directly from the publisher at reg-books.com. That's reg-books.com. If you are interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.